in Atal Bihari Vajpayee Institute of Medical Science and Dr. RML Hospital. His area of interest is airway and ultrasound in anesthesia.
The topic of our presentation is inhalational agent. Inhalation agent is a chemical compound possessing general anesthetic property that can be delivered via inhalation into the body via the lungs and are distributed with the blood into the different tissue. The main target of inhalation anesthetics is the brain. Inhalation anesthetics act either by amplifying inhibitory function or decreasing excitation at the nerve ending in the brain. The demonstration of the anesthetic property of the diethyl ether by William Morton in 1846 was one of the most significant discoveries in medical science. Thereafter, many other anesthetic agents were introduced into the clinical practice. Unfortunately, some of these anesthetics were explosive or toxic and have since been discontinued for clinical use. In 1950, the first fluorinated agent was tested in the clinical trial. However, the drug was withdrawn in 1974 with toxic effect was observed. In 1957, halothane, a halogenated hydrocarbon, was tested in clinical practice and successfully applied for surgical anesthesia. Isoflurane was synthesized in 1965. However, it was introduced into widespread clinical use in 1983 due to very difficulty in chemical synthesis. Sevoflurane and desflurane was developed in the late 1960s and tested in clinical practice much later. Sevo was not immediately introduced because of its fluorine releases and its reaction with absorbed carbon dioxide. Now coming to the ideal anesthetic agent has some properties, mainly physical, pharmacodynamic, and pharmacokinetics. First, we will discuss physical properties. An ideal anesthetic agent should be non-inflammable, non-explosive, stable in light, liquid and vaporizable at room temperatures, stable at room temperature with long shelf life, stable with soda lime, environmental friendly, cheap and easy to manufacture. And it should be pleasant to inhalation, so non-irritant, low blood gas solubility that is faster in onset, high oil and water solubility that is high potency, minimal effect on other systems, no biotransformation, and should be non-toxic to OT personnel. It should have a predictable dose response seen at discretion. It should have an analgesic, antiemetic, and muscle relaxation property. Should have a minimum respiratory depression and minimum cardiovascular effect. There should be no increase in cerebral blood flow and intracranial pressure. Do not impair renal or hepatic function, and this should have no effect on the smooth muscle of uterus and do not trigger malignant hypothermia. Inhalation anesthetic agents are classified as gaseous and liquid, volatile liquids. All anesthetic agents are inhalation agents are among the most rapidly acting drugs. Nitrous oxide and xenon are true gases, and other agents are the vapor of anesthetic liquid. But for simplicity, all of them are referred to as gases because they are in the gaseous phase when administered into the lungs. These agents are non-ionized and have low molecular weights. This allowed them to diffuse rapidly without the need for facilitated diffusion or active transport from bloodstream to tissue. The other advantage of gases is that they can be delivered to the bloodstream via a unique route available in all the patient, the lung. Speed, gaseous state, and the lung as a route of administration combine to form the major beneficial feature of the inhalation agent. Now we will consider some physical and chemical properties of inhalation agents. First, coming to the permanent gases, the so-called permanent gases such as oxygen and nitrogen exist only as a gas at ambient temperature. Gases such as nitrous oxide can be compressed into liquid under high pressure at ambient temperature. Most potent volatile anesthetics are the liquid at ambient temperature and pressure. I will describe the vapor pressure and boiling point. If the system in which the volatile liquid reside in a closed container, molecule of the substance will equilibrate between the liquid and the gas phase. At equilibrium, the pressure exerted by the molecule collision of the gas against the container wall is called the vapor pressure. Vapor pressure determines how readily an inhalation anesthetic agent will evaporate in the anesthesia machine vaporizer. The boiling point of the liquid is the temperature at which the vapor pressure exceeds atmospheric pressure in an open container. This tabular shows that the boiling point of vapor pressure of the inhalational agent. As you can see, that desperate vapor pressure is 3 to 4 times that of a contemporary inhalation anesthetic, and its boiling point is 22.8%, which is near room temperature. The bottle of the desflurane is designed to allow transfer of desflurane from the bottle to the vaporizer without exposure to the atmosphere. Desflurane cannot be administered using a standard vaporizer, that is the variable bypass, but by a vaporizer that add agent directly to the bloodstream. Each coefficient is the ratio of the concentration of the anesthetic gases in each of the two phases at the equilibrium. Equilibrium is defined as the equal partial pressure in the two phases. The blood gas partial coefficient of isoflurane is 1.4 and brain blood partition coefficient is 2.2. At equilibrium, the volume of the blood contained 1.4 fold the quantity of isoflurane as the same volume of the alveolar gas, whereas the volume of the brain tissue contained 2.2 fold the quantity of the isoflurane as in the volume of the blood. For instance, the blood gas partial coefficient of nitrous oxide is 0.47. In other words, at equilibrium, the 1 ml of blood contains 0.47 as much nitrous oxide as does 1 ml of alveolar gas, even though the partial pressure are the same. Nitrous oxide is much less soluble in blood than halothane, which has a blood gas partial coefficient of 2.4. Thus, almost 5 times more halogen than nitrous oxide must be dissolved to raise the pressure of the blood. So this is a table where show the blood gas partial coefficient. Nitrous is the least and the halogen has the highest blood gas partial coefficient. Now coming to the concentration effect. The higher the concentration of an inhaled anesthetic, the faster the alveolar concentration approaches the inhalational concentration. This is referred to as a concentration effect, and it is clinically significant only in cases where gases are administered in a high concentration and having a relatively low blood gas solubility coefficient, for example, nitrous oxide. This has been termed the concentration effect, which is readily the result of two phenomena, the concentrating effect and the augmentation inflow effect. Now, this is a diagram that shows the concentration effect. Suppose the capacity of the patient lung is 4 liter. As the patient inhaled 2 liter nitrous oxide and 2 liter of oxygen, such that each has a 50% concentration in the mixture. We all know that the gas flow along the concentration gradient, that they maintain equilibrium. Since nitrous oxide diffuse very rapidly, very rapidly than other gases, half of the volume, that is 1 liter of the 1 liter of it diffuse into the blood, leaving only 1 liter in the alveoli. Initially, for 2 liter of nitrous and 2 liter of oxygen of the alveoli has been now reduced to 1 liter of nitrous oxide and 2 liter of oxygen. So the new concentration of the nitrous oxide in the alveoli is 1/3, that is 33%. This is the first part of concentration effect, and it is termed concentrating effect. As the alveoli is deficient in 1 liter volume, this creates a subatmospheric pressure in the alveoli, and the patient further inhaled 1 liter of mixed gases, which contain 500 ml of nitrogen and 500 ml of oxygen. Now the volume of the gas in the alveoli is 4 liter, 2.5 liter of oxygen and 1.5 liter of nitrous oxide. Now the concentration of nitrous oxide in the alveoli is approximately 37.5%. This is the second part of concentration effect, and it is termed as augmented gas inflow, or the ventilation effect. In comparison to this, If we use a mixture of 10% nitrous oxide and rest is 90% oxygen, the rise in the alveolar concentration is obviously very low, that is 5%, around 5.3% by concentrating effect, and 5.5% by the augmented inflow effect, which is around 5 times and 6.8 times less as compared to 50-50 mixture. So given 5 times as much inhalational agent has led to 6.2 times greater alveolar concentration. So the higher the Fi, the greater the effect. Thus, nitrous oxide typically given in concentration of 550 to 0 to achieve a higher concentrating effect. Now coming to the second gas effect. Second gas effect is not a different concept than the concentrating effect. It is a special case of concentration effect and applied to the administration of a potent anesthetic with a nitrous oxide. Along with the concentration of potent agent in the alveoli via its uptake, there is a further concentration via the uptake of nitrous oxide, a process called the second gas effect. Though it has a low solubility in blood, although 1 liter per minute of nitrous oxide enters the blood in the first few minutes. If another potent anesthetic, second gas, is given at the same time, it also will be delivered to the blood at the rate of 1 liter per minute, higher than the minute ventilation, and induction will be faster. So this can also explain by the same diagram. We'll use the same diagram to explain the second gas effect by adding isoflurane, so that the inhalation mixture is now 1% isoflurane, 49% oxygen, and 50% nitrous oxide. 4 liters is inhaled by the patient, that is 40 ml isoflurane, and rest of the nitrous and oxygen. We will use this. So now the concentration effect is as half the nitrous oxide is diffused quickly into the alveoli, the alveolar volume will reduce, and a new alveolar concentration of isoflurane will be 1.33%, and this is a concentrating effect. If fresh flow of oxygen, nitrogen, and isoflurane is given, then again there will be concentrating effect, and due to the subatmospheric pressure created in the alveoli, further of the mixture gas is inhaled. So the new alveolar concentration of the isoflurane gradient is approximately 5.5%. So this is a second gas effect. Nitrous oxide increases the alveolar concentration of the second gas like halothane and isoflurane, etc. Now coming to the minimum alveolar concentration, Eager and his colleague defined the concept of minimum alveolar concentration of an inhalation anesthetic is the alveolar concentration that prevents movement in 50% of patient in response to a standard noxious stimulus at 1 atmospheric pressure at 37 degrees centigrade. For human, the noxious stimulus is a surgical incision on the abdomen, while in animal, it is usually produced by clamping of the tail or passing electric current to the subcutaneous electrode. Minimum alveolar concentration is it mirrors brain partial pressure after a period of equilibrium. Best estimation of anesthesia potency of the inhalational agent. It allows comparison between agent and provide a standard for experimental evaluation. Doses of anesthetics in MAC are additive. MAC is a constant with a variety of noxious stimulus. Individual variability is very small. So this is a developed diagram that shows the agent and the MAC of different inhalational agent. Now coming to the factor affecting MAC, they may be physical, pharmacological, and pathological, but to the physiological factors. Factors such as species, sex, hyperthyroid, or duration of anesthesia do not affect MAC. However, the age of the patient does influence the minimum alveolar concentration. MAC peak at the age of 6 months of age and then decrease by approximately 6% per decade regardless of the volatile anesthetics. Now coming to the physiological derangement. Severe physiological derangement such as anemia, hypercarbia, hypoxia has been shown to decrease MAC. Temperature is also a consideration that can influence the MAC of a volatile anesthetic. MAC decreases with decreasing body temperature by approximately 4 to 5% and increases by increasing the temperature. Exception to this is the nitrous oxide. MAC does not changes with decreasing temperature. A special population to consider are those who are pregnant. Although the underlying cause is unclear, it has been found that MAC requirements are decreased during pregnancy by as much as 30%. The increased potential of volatile anesthetic for this population also extended into early postpartum period. Many pharmacological agents altered MAC, commonly used classes of drugs in anesthesia such as sedative, hypnotic, intravenous drug that would potentially GABA, local anesthetic, opioid, all decreases MAC. These include medications such as barbiturate, benzodiazepine, propofol. Ketamine, lithium, aromatase decreases the MAC. Stimulants such as cocaine, ephedrine increases MAC. Substances such as alcohol and amphetamine depend upon the chronicity of the use. Chronic alcohol use and acute amphetamine use increases the MAC requirement, while the inverse decreases MAC requirement. Coming to the pathological factors, patient presenting with depressed level of consciousness due to trauma or the cerebral vascular insult lead to decrease in the anesthetic requirement. Hypoxia below 30 millimeter of mercury, acute metabolic acidosis, and acute hemorrhage hypertension also produce decrease in MAC. Certain electron abnormalities such as hypernatremia are associated with increase in MAC, while hyponatremia is associated with decrease in MAC. Now coming to the clinical implication of MAC. Both minimal alveolar concentration and lipid solubility vary among different volatile anesthetics. The most commonly used anesthetic follow the order of nitrous oxide, desflurane, SIBO, isoflurane, halocin from highest to lower MAC. This order follows the Mayer's-Overton rule and has a direct correlation with oil-gas partition coefficient. It also used to study the side effect of inhalation agent at equipotent doses. When combined inhalation agent is given, the MAC is roughly added together. It also used tool to measure anesthetic potency, small for the potent anesthetic halothane and a larger for the less potent anesthetic nitrous oxide. Besides immobility, MAC can be used clinically to assess unconsciousness, amnesia, eye opening, and autonomic response, using the concept of MAC awake, MAC amnesia, MAC bar. MAC awake is defined as the anesthetic consideration needed to suppress the voluntary response to verbal command. It is generally 1/3 of the MAC for inhalation anesthetic. The MAC for endotracheal intubation is defined as the end tidal concentration of inhalation anesthetic agent at which 50% of the patient can be intubated smoothly. The concept of MAC bar is estimated of the MAC of volatile anesthetic that block autonomic response to surgical incision in 50% of the patient. MAC bar is determined by measuring the level of catecholamine in the venous blood and has been calculated to be roughly 1.5 MAC. Now coming to the limitation of MAC. One of the major limitations is that it is not applicable when administering total and intravenous anesthesia. Furthermore, in clinical practice, it is common to administer balanced anesthesia, including the use of muscle relaxant, intravenous anesthesia, opioid. While these drugs tend to decrease MAC, but may not equally affect MAC awake and MAC amnesia. Therefore, MAC cannot be used as a sole measure of anesthetic effects. Now we will discuss individual anesthetic agents. First is nitrous oxide. It is a laughing gas, only inorganic anesthetic gas in clinical use. It is a colorless, odorless, non-explosive, non-inflammable nitrous oxide, but nitrous oxide is capable of supporting combustion. Nitrous oxide is a gas at room temperature and ambient pressure. It can be kept as a liquid under pressure because its critical temperature lies above room temperature, that is 36.5 degrees centigrade. Nitrous oxide is a relatively inexpensive anesthetic gas. Now discuss effect on the different organs. In cardiovascular, nitrous oxide has a tendency to stimulate the sympathetic nervous system. Arterial blood pressure, cardiac output heart rate are unchanged or slightly elevated because of its stimulation of catecholamines. Constriction of pulmonary vasculature smooth muscle increases pulmonary vascular resistance, which result in the elevation of right ventricular and diastolic pressure. But nitrous oxide increases endogenous catecholamine level. It may be associated with a high incidence of epinephrine-induced arrhythmia. On respiratory system, nitrous oxide increases respiratory rate and decreases tidal volume as a result of central nervous system stimulation and activation of pulmonary stretch receptors. The net effect is minimal change in minimum ventilation and resting arterial CO2. It increases cerebral blood flow and cerebral blood volume and also mildly elevate intracranial pressure. It also increases cerebral oxygen consumption. On neuromuscular effect, in contrast to other inhalational agents, nitrous oxide does not provide significant muscle relaxation. It decreases renal blood flow and increases renal vascular resistance, leading to decreased GFR and urine output. Hepatic blood flow also falls, but to a lesser extent than other agents. It causes post-operative nausea or vomiting by stimulation of chemocenter, trigger zone, and vomiting center in the brain. During emergence, almost all of the nitrous oxide is eliminated by exhalation. A small amount diffuses through skin. Biotransmission limited to less than 0.01% through that undergo reductive metabolism in the gastrointestinal tract by anaerobic bacteria. Advantages are, it is odorless adjuvant at the beginning of the inhalation. So it is used as adjuvant at the beginning of the inhalation in the pediatric population prior to the administration of volatile anesthetic. Anesthetic property allows the reduction of halogen agent and limit the cardiorespiratory effect in critical ill patient. It is also commonly used for analgesia and sedation for dental procedure. It provides the enhancement of pain sensitivity induced by noxious input and by acute phenytoin and morphine tolerance. The disadvantage is interaction of nitrous oxide with beta B12. Vitamin B12 play a critical role in methylation reaction, methylation reaction, and DNA synthesis. It inactivates enzyme methanion synthesis, which required both beta 12 and folate as a cofactor. Mainly the disadvantage in healthy surgical patients, megaloblastic changes in the bone marrow are rare and reported only after a prolonged period of exposure more than 12 hours to nitrous oxide. However, in severe ill patients or those with a risk factor, there is shorter interval at 2 to 6 hours or repeated exposure period of nitrous oxide exposed may lead to significant subacute pathology. The risk factor that increases susceptibility to nitrous oxide toxicity include pernicious anemia, gastrointestinal absorption syndrome, extreme ophagies, alcoholism, malnutrition, a strict vegetarian diet, or inborn deficiency in cobalamin or tetrahydrofolate metabolism. Megaloblastic bone marrow changes can be induced after a short period of 2 to 4 in these patients. During recovery from anesthesia, when nitrous oxide discontinued, large concentration of nitrous oxide diffuses back into the alveoli from the blood. This is due to the low blood solubility of nitrous oxides and result in dilution of inspired oxygen concentration and hypoxia, and dilution of inspired carbon dioxide concentration and subsequent decrease in arterial carbon dioxide concentration, leading to reduce in respiratory drive. This is known as diffusion hypoxia. The risk persists only for the initial 3 to 5 minutes of discontinued nitrous oxide. Therefore, it is appropriate to initiate recovery with 100% oxygen inhalation to prevent diffusion hypoxia. But long exposure to the nitrous oxide can result in bone marrow depression and even neurological deficiencies. Because of possible teratogenic effect, nitrous oxide is often avoided in patients who are pregnant. Nitrous oxide may also alter the immunogenic response to infection by affecting chemotaxic and motility of polymorph leukocytes. Nitrous oxide is contraindicated in air embolism, pneumothorax, acute intestinal obstruction, intracranial layer, closed cavities. Because nitroxide is 35 times more soluble than nitrogen in blood, thus it has a tendency to diffuse into the air-containing cavities more rapidly than nitrogen is absorbed into the bloodstream. Attempt to replace nitrous oxide with other gases lead to the discovery of xenon. Xenon has been suggested as an ideal inhalational agent. It is a stable, non-biotransferable, non-toxic, non-inflammable, non-irritant, and have a low blood gas partial coefficient. Xenon is a chemical element with the symbol Xc and atomic number 54. It is a colorless, heavy, odorless, noble gas that occurs in the atmosphere in a trace amount. Xenon is a high affinity NMDA receptor antagonist. Xenon inhibits nicotinic acetylcholine alpha 4 beta 2 receptor, which contribute to a spinal mediated analgesia. Compared with a volatile anesthetic and propofol, anesthetic emergence is faster with xenon. It shortened time to extubation, associated with a better neurological outcome. Xenon was associated with faster emergence and with a better early post-operative cognitive recovery, and it has a more stable intraoperative hemodynamic response. It is a sympathetic stimulator and better maintains systolic, diastolic, and mean arterial pressure and reduces heart rate. The disadvantages are because of high density and viscosity, the air resistance is greater as compared to other inhalational agent. Xenon is the only inhalational agent that causes a decrease in respiratory rate, and it is also associated with a high incidence of post-operative nausea, vomiting, and high cost. Now there is a comparison of xenon with nitrous oxide. As you can see, the diffusion of hypoxia is not there with xenon, but with nitrous oxide. And there is a gaseous expansion is also there with nitrous and not with the xenon. Now coming to the diethyl ether. It is prepared originally by the sweet oil of vitriol. It is introduced in profession by Morton on October 16, 1846. And the classical stage and plain anesthesia is described using ether. Now coming to physical property, it is a colorless, pungent, volatile liquid. Blood gas solubility is 12, MAC is 2 to 3. It is relatively inert, stored in a cool, dark place, unaltered in the body 80 to 90% by the lungs, and 50% metabolized in the liver. It is inflammable in air and explode in oxygen, in the presence of oxygen. Effect on the organs are increases the heart rate first, and later the heart rate become normal. Blood pressure increases after the first year, and there is a vasomotor center paralysis in deeper plane. It also increases sympathetic activity because of the secretion of noradrenaline. On the cardiac output, lighter plane increases the cardiac output, but deeper plane it decreases the cardiac output. Arrhythmia is rare with the ether and is safer to administer with arrhythmia. On respiratory system, respiratory increases first and then later on decreases. Since it is irritant, ether vapor irritant, and increased secretion because of laryngospasm, but it dilate bronchial musculature. It increases cerebral blood flow and increases cerebral CSF pressure. On sympathetic nervous system, increases catecholaminergic level, increases heart rate. It increases production of glycogen, so increases blood pressure. It dilates gut and inhibit the movement of gut, and there is dilatation of pupil. On alimentary system, post-operative nausea vomiting more than 50%. There is stimulation of salivary gland and gastric atony. Advantages are it related non-toxic, safe and potent, cheap, can be used without sophisticated apparatus, excellent relaxation, maintain BB and no tendency to arrhythmia. But because of disadvantage, it has not been used now. Because of increased secretion, induction and recovery is slow, And mainly it is inflammable, explode and spark flame, and can cause laryngospan. So better agents are available, so it is not used now. Now coming to the halothane. Halothane is a halogenated alkanes synthesized in 1951. It is non-flammable, non-explosive nature. Thymol is a preservative and stored in amber color water to retard spontaneous oxidative decomposition. MAC is 0.7%. It is the most potent inhalational agent. It has a low blood gas coefficient of 2.5. So an induction of acid is really rapid. Pleasant odor. It is used as an inducing agent for pediatric population, but sevoflurane is better. The effect of different organs. A dose-dependent reduction of arterial blood pressure occurs, which is due to direct myocardial depression. 2 mg of halothane result in 50% decrease in blood pressure and cardiac output. Although halothane is a coronary artery vasodilator, it also decreases coronary blood flow due to the drop in systemic arterial pressure. Adequate myocardial provision is usually maintained as oxygen demand also drops. Normally, hypotension inhibit baroreceptor in the aortic arch and carotid bifurcation, causing a decrease in vagal stimulation and compensatory rise in heart rate. However, halothane blunt this reflex, and there is slowing of SA node conduction may result in junctional rhythm or bradycardia. In infant, halothane decreases cardiac output by combination of decreased heart rate and depressed myocardial contractibility. However, halothane interferes with slow calcium channel conduction. This leads to halogen causing sensitization of heart to the rhythmogenic effect of epinephrine, so that a dose of epinephrine above 1.5 mg per kg should be avoided. On respiratory system, halothane typically causes rapid and shallow breathing. The increased respiratory rate is not enough to counter the decreased tidal volume, so alveolar ventilation drops and resting partial pressure of CO2 is elevated. Halothane attenuate arterial airway reflexes and relax bronchial smooth muscle by inhibiting intracellular calcium metamobilization. Halothane is a potent bronchodilator and is often refers asthma-induced bronchospasm. In fact, halothane is the best bronchodilator among the currently available volatile anesthetics. Halothane also depresses clearance of mucosa from the respiratory tract, promoting post-operative hypoxia and atelectasis. On the cerebral circulation, halothane lowers cerebral vascular resistance and increases cerebral blood flow. Autoregulation is blunted. Concomitant rise in intracellular pressure can be prevented by establishing hyperventilation prior to the administration of halothane. Cerebral activity decrease leading to electro EEG slowing and modest reduction in oxygen requirement. Halothane potentiate non-depolarizing neuromuscular blocking agent, and it is also a trigger agent for malignant hyperthermia. It reduces renal blood flow, leading to GFR and renal output. It relaxes uterine muscle, may cause postpartum hemorrhage. Decreases blood flow proportional to the depression of the cardiac output. Two major types of hepatotoxicity are associated with halothane administration: type 1 hepatotoxin, type 2 hepatotoxicity. First, we will discuss type 1 hepatotoxicity. It is a benign, self-limited, relative common, and is marked by mild transient increase in serum transaminase and glutathione as transferase concentration. Hepatotoxicity is not characterized by jaundice or clinical evident hepatocellular disease. It results from the reductive biotransformation of halothane rather than the normal oxidative pathway. It does not occur following administration of other volatile anesthetics because they are metabolized to a lesser degree and by different pathway than halogen. Coming to the type 2 hepatotoxicity, and it is also called halothane hepatitis. It is associated with massive central-lobular liver necrosis that lead to fulminant liver failure. The fatality rate is around 50%, and it is characterized by fever, jaundice, grossly elevated serum transaminase level. Hepatotoxicity appear to be immune-mediated. Halothane oxidizes oxidized metabolized, producing trifluoroacetyl metabolite to an intermediate compound. These metabolites bind liver protein and it is genetically predisposable. Antibodies are formed to this metabolite protein complex. These antibodies in turn mediate subsequent type 2 toxicity. Volatile anesthetics other than halogen also have the potential to cause type 2 hepatotoxicity. The risk factors for hepatic hepatitis are multiple exposures, prior history of post-anesthetic liver or fever or jaundice, obesity, female sex, middle age, genetic predisposition, enzyme inducers, high EST and bilirubin level. Pre-existing liver disease itself is not a risk factor for halogen hepatitis. Contraindication. Halogen should not be used in unexplained liver dysfunction following previous exposure. It should not be used in intracranial mass lesion because of possibility of intracranial hypertension. Hypovolemic patient and patient with severe cardiac disease may not tolerate halogen-induced negative inotropic effect. And sensitization of heart to ketamine limits the usefulness of halogen when exogenous epinephrine administered or in a patient with pheochromocytoma. Now coming to the enflurane, it is an isomer of isoflurane. MAC is 1.68. It is sweet and sweet odor and generally do not sensitize the heart to the catecholamines. Now coming to the systemic effect, the administration of allofurin has been known to decrease systemic vascular resistance. This effect causes decreased blood pressure. It also causes concentration-dependent decrease in heart rate and increased left atrial pressure. On respiratory system, it is a inhalation agent that has been shown to have potent bronchodilator property. Along with the bronchodilator, inhalation anesthetic decreases airway responsiveness and reduces histamine-induced bronchospasm. On the neurology, it increases cerebral blood flow in comparison to the halogen. Seizure occur at a deeper level and contraindicated in epileptic patient. Side effect is hepatotoxic and it is also nephrotoxic because of fluoride. Now coming to the isoflurane. Isoflurane is an isomer of enflurane. It is non-flammable, colorless, volatile liquid, stable, no preservatives is required. It has a rapid induction. It is pungent smelling. So can produce cough, breath holding. It has a low blood gas partial coefficient of 1.4. So rapid induction and recovery. On the effect on the organ, on the cardiovascular, it causes minimum cardiac depression. Cardiac output is maintained by rise in heart rate due to partial preservation of carotid baroreceptors. Mild beta adrenergic stimulation that lead to decreased systemic vascular resistance causes decreased arterial blood pressure. It increases dilate coronary artery, lead to coronary steal syndrome. On respiratory system, it is a respiratory depressant. Tachypnea is less pronounced as compared to other volatile anesthetics agent. The neck defect is a pronounced fall in minute ventilation. Due to its tendency to irritate upper airway reflexes, idoflurane is considered as a bronchodilator, but not as potent as halogen. Coming to the cerebral circulation, at concentration greater than 1 mg, isoflurane increases cerebral blood flow and intracranial pressure. These effects are reversed by hyperventilation. Isoflurane reduces cerebral metabolic oxygen requirement, and at MAC of 2, it produces an electrical silent EEG. EEG suppress provides some degree of brain protection during episode of cerebral ischemia. Isoflurane relaxes skeletal muscle. It also decreases cerebral blood flow, GFR, and urine output. Advantages are it has rapid induction and recovery, little risk of hepatic or renal toxicity, cerebrovascular stability is there, muscle relaxation is there. Epinephrine can be administered safely in a dose of up to 4.5 mg per kg. But disadvantages are pungent smell, coronary vasodilatation lead to coronary artery syndrome. Now coming to the desflurane, it has a structure similar to that of isoflurane, pungent smell, expensive agent, blood pressure coefficient is 0.25. The low solubility of desflurane in blood and blood tissue causes very rapid wash in and wash out of anesthesia. Therefore, the alveolar concentration of the desflurane approach is an inspired concentration much more rapid than the other volatile agent, giving the anesthesiologist tighter control over anesthesia level. The recovery time is approximately 50% less than that of isoflurane. It is eliminated by lung primary only and 0.025% is metabolized in the liver. The vapor pressure of desflurane is at 20 degree temperature is 681 millimeter of mercury. This problem necessitates the development of a special heated electronic precise vaporizer TEC6, a high vapor pressure and ultra short duration of action and moderate potency are the most characteristic feature of desflurane. Now coming to the systemic effect on the cardiovascular, it has a similar effect. It has similar effect to isoflurane. It increases the heart rate and decreases both mean arterial pressure and systemic vascular resistance while maintaining cardiac output. Unlike isoflurane, desflurane does not cause coronary steal syndrome. On respiratory system, it causes decrease in tidal volume and increase in respiratory rate. Since it is a pungent and irritated airway during desflurane, induction can be resisted by salivation, breach, cough, and laryngospasm. These problems make desflurane less than ideal suited for inhalation induction. On the cerebrovascular effect, it dilates the cerebrovascular leading to cerebral blood flow and increase intracranial pressure. Countering the decrease in cerebral vascular resistance is a marked decline in the cerebral metabolic rate of oxygen that tend to cause cerebral vasoconstriction and moderate any increase in cerebral blood flow. It also has a skeletal muscle relaxant in a dose-dependent manner at isoflurane. There is no evidence of an nephrotoxic and hepatic function is also preserved. Contraindications of desflurane is mainly it should not be used severe hypovolemia, patient having a history of malignant hypothermia, and intracranial hypertension. Regarding drug interaction, epinephrine can be administered safely in a dose up to 4.5 mg per kg as a desflurane does not sensitize the myocardium to the arrhythmogenic effect of epinephrine. Desflurane emergence has been associated with delirium in some pediatric population. Now coming to the sevoflurane, it is non-flammable, pleasant smelling, non-irritant, stable. Cost is about 10 times more than the isoflurane. MAC varies from 1.4 to 3.3%. It has a low blood gas partial coefficient of 0.65. So it is a rapid fall in concentration upon discontinuation and a more rapid emergence compared with isoflurane. On the systemic effect, sevoflurane mildly depressed myocardial contractility. Cystic vascular resistance and arterial blood pressure declines slightly less than that with isoflurane or desflurane. There is no evidence that sevoflurane is associated with coronary steal syndrome, but it may prolong the QT interval. On the respiratory system, it is non-irritant and very less respiratory depression. Cerebrovascular, same as isoflurane effect. On the neuromuscular effect, sevoflurane has the same neuromuscular effect. Sevoflurane produces adequate muscle relaxation for intubation of child following inhalational induction. Advantages of sevoflurane are, since it is non-pungenting and rapid increase in alveolar anesthetic concentration makes sevoflurane as an excellent choice for smooth and rapid inhalation induction in pediatric and adult population. Rapid induction and recovery. In fact, inhalation induction with 4 to 8% sevoflurane in 50% mixture of nitrous oxygen can be achieved in approximately 1 to 3 minutes. It does not sensitize the myocardium to the catecholamine as much as halothane and do not result in carbon monoxide and do not result in carbon monoxide production with the dry soda lime. Disadvantages are it is less potent than the similar halogenated agents, interact with carbon dioxide absorption in the presence of soda lime and more with the barium lime. Compound A is produced. which is toxic to brain, liver, and kidney. About 5% is metabolized, and there is elevation of serum fluoride level that lead to concern about the risk of renal toxicity. Post-operative analgesia may be more common in children than seen in halogen. Thank you. Any questions?
Thank you, Dr. Sanjeev, for nice and detailed presentation on inhalation anesthetic agents. Any question from the audience?
No, ma'am, there are no questions.
Okay, we can wrap now.
Yeah.
Thank you, Nitin.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, sir, for your wonderful presentations. Thank you, ma'am, for being there.
Utash, chale. वैसे रोज लेके आता है
We'll take 2 minutes break and we'll shortly resume after the 2 minutes break. Welcome back. We'll begin with our last session for the day.
Yeah, now I joined.
Yeah. Welcome, sir.
Thank you.
So for this session, I would like to invite Dr. R.P. Gedu. Sir is Professor in Anesthesia and Head of the Department Pain Medicine at D.Y. Patil Medical College, Navi Mumbai. Sir's area of keen interest are difficult airway, cancer pain, acute pain service, cancer, and anesthesia. Sir has several achievements to his credit. Paper setter for MTA, PhD, DNP, DCCAs, has been an editor of 928 chapters, has been a faculty for various international conferences and countries. So has more than 400 lectures in national and international conferences and has been selected as a specialist in anesthesiology by NBE and is selected as a convener for pain medicine fellowship by NBE. We welcome you, sir. It's a pleasure to have
Thank you.
you as a chairperson for this session. Over
Thank
to
you,
you, sir,
thank
for the proceedings of this.
Yeah. Now I think there's a very nice speaker, Dr. Rakesh Garg, who's going to speak on to the vaporizers, both I think old and new vaporizers. I'm sure that it will be very useful for all the PG students who are going to be appearing for MD, DA, DNB, etc. So Rakesh Garg normally doesn't need any introduction, but recently has been elected as a editor for the Indian Journal of Anesthesia, which is a most proud moment for him also. So, Rakesh, you can join. Start.
Thank you so much, sir. Thank you for the kind words, and thank you, Professor MD Kaur, Madam, and the whole team of RML for this kind invite for this academic extravaganza of APPEC 2023. So I take you through vaporizers, which is one of the very important aspect when we talk about the clinical aspect or when we talk about the exam point of view, because we should be aware of the vaporizers as a whole, though we may not be using